ahead. So the first thing which you must, when we also started long back, maybe about 25 years back, we started. So we were not taught this way, but I think this is the right way to know. First is you must palpate. You should know where is the internal iliac artery. So it is always good that you palpate the sacral promontory, which we all uterus. We normally many people would deliver the uterus out. So even if you have not you stitch the uterus while it is inside the abdomen, please bring it out. Every case bring it out and palpate the sacral promontory. वो दिखता है पतले पेशेंट में दिखता है, otherwise you can palpate. And once you palpate, go slightly above it and you will feel the aorta. That is at L4. Is it right? So that is what is visible here. So this is the aorta, L4, and from the aorta you will then start palpating. You will feel the common iliac arteries, right? Then come down in front of the sacroiliac joint. The common iliac artery divides into external and internal iliac artery. Abhi, when you do this, you can palpate the external iliac artery along the lateral pelvic wall. Internal iliac artery may not be palpable, that goes more posteriorly. Is it right? So this is something which you should get familiar with. पहले ये तो पता हो कि हमें, so if we have to reach the internal artery, we have to open at the level of sacroiliac joint. उसके पास में, if you get lost any time, where are we? When you open the retroperitoneum, sacrum को palpate कीजिए और उससे आगे आइए और आपको पता चलेगा कि आप ठीक जगह है या नहीं है. Is it right? So I think that is what is important. So this is how you should start. And then this is the picture which shows you that at the sacroiliac joint, external iliac artery, we normally would say that it forms a V like this. So this goes, a common iliac goes like external iliac इधर चला जाता है और internal iliac नीचे आ जाता है, नीचे और थोड़ा पीछे, right? So there are two V's. One is the V of common iliac, and second V is of the external and internal iliac. Or this is how it goes, right? Now, how to remember the branches? Branches आप remember करें या नहीं करें वो इतना matter नहीं करता, but just to be, we should know what it is and why do we do certain things certain way. So that is why this is a mnemonic. Somi, I love you. So we start with it. So basically, this is just to show you that at the sacroiliac joint, you have anterior, the internal iliac artery would further. अभी external internal हो गया, अभी third V आ गया. So the internal iliac artery would then divide into anterior and posterior division. So the posterior division goes posteriorly, जो normally हमें नहीं दिखता. So what we see is the anterior division. Is it right? So that is it. So now looking at the artery and your superior gluteal artery. So it is important that we do not ligate the internal iliac artery before this division is given. Because why unnecessarily stop blood supply to the muscular part of the back and the buttocks? Is it right? So that is why we always ligate it 3 to 4 centimeter below the division of into anterior and posterior division, into the external and internal iliac. So that is the division of the common iliac into internal and external iliac. So you will follow the internal iliac and go 3 centimeter below. And if you ligate it that time, the posterior division is already given. आपको उसको देखने की जरूरत नहीं, पर वो presumed है कि वो नहीं आएगा. So that means you are ligating only the anterior division. So that is another very important practical point, right? So anterior division will give a superior vesical artery, it will give a obturator artery, it will give a uterine artery, middle rectal, inferior gluteal, internal pudendal and inferior vesical. So ये सब हमें नहीं देखना है. हमारा focus, किसकी आंख और अर्जुन की जो निशाना वो वाला कि योर फोकस शुड बी कि हमें एंटीरियर डिवीजन को ट्रेस करना है इंटरनल iliac आर्टरी की और 3 सेंटीमीटर नीचे हमें उसमें एक लूप थ्रेड करना है. सो दैट इज ऑल व्हाट यू विल लुक एट. इज इट राइट? बट जस्ट फॉर योर नॉलेज दीज आर द ब्रांचेस व्हिच विल बी देयर एंड सो यू कैन क्लासिफाई देम इनटू 2 + 4 + 4. So 2 branches are which supply the back. And there are 4 branches which leave the pelvis, वो pelvis के अंदर नहीं होती, and 4 branches which are inside the pelvis और वो pelvis को supply करती है. So the 2 branches which supply the back, you can see this red portion. This is all supplied by those branches. This is iliolumbar and lateral sacral. Both are the branches of posterior division, right? If you look at this blue area here, this is the branches which leave the pelvis. And they are obturator artery, superior gluteal, inferior gluteal and internal pudendal artery. So ये बाहर निकल जाती हैं. So these are the ones. And the 4 which are there in the pelvis would be the, these are the, this grey area is the one where they are within the pelvis, and this is umbilical artery, superior vesicle, and inferior vesical artery, and uterine artery. So these are the ones which are there. और ये हमें, when Dr. Deepak is going to talk about, he will tell you about these arteries. So these are, because they are within the pelvis. So these are the arteries which you might encounter, and you must know what is the, how are they distributed. So I think I can, yeah. Another important thing is that the umbilical artery, if you look here, the umbilical artery is the green one. So the umbilical artery, goes up. It goes up as obliterated umbilical artery. जब आप abdomen खोलते हैं तो आपको, this is seen as the median umbilical ligament. Center में urachus होता है. Then you have two folds. So that is the median umbilical ligament. And this artery is used for actually tracking when you do an extraperitoneal approach. So this is why we are showing you, and this is the picture which tells you. So when we do laparoscopy, we see that there is one median fold, is it right? And there are two, medial umbilical folds, is it right? So these are the obliterated umbilical arteries, is it right? But they are branches of internal iliac artery, anterior division of the internal iliac artery. So that is what you must remember. And I think I can leave these, all these, keeping in mind the time. So this is the anatomical model. So here, if we look at it, so this is the external iliac artery. I told you it goes straight, is it right? This is the internal iliac artery, right? And this is the posterior division, and this is the anterior division, which is turning up as obliterated umbilical artery. Is it right? So this is how, and these are the branches which are coming. So these would be the, you will have the uterine artery, then you will have the vaginal artery, and all these arteries, inferior vesicle, and all those arteries. Is it right? So this is how it is. And also you need to see that the external iliac vein is medial to the external iliac artery, right? External iliac artery, we are going from lateral to medial side, lateral to medial side. So external iliac artery दिखी, फिर external iliac vein दिखा, फिर internal iliac artery दिखा. Is it right? So while we are doing suction and we are exposing that area, we should know ये तीन ऐसे placed हैं कि पहले external iliac artery वो सबको इंटरनल iliac artery बिना dissection के नहीं देखेगा. So external iliac artery के साथ में आपको external iliac vein दिखता है. That's easily visible in most of the patients. Is it right? तो जब पेरिटोनियम खोला होगा, तो अगर हम external iliac vein के और medial आएंगे, that is the place where we are going to see internal iliac artery. Is it right? So once we keep that in mind, then it becomes easier. All right. So this is just showing all that, and I think this is showing the posterior branches. So once this artery is given, so this is where we are going to ligate. This is where 3 centimeter from the division. Is it right? So that is where we would go, and I think, yeah. So this is showing the umbilical artery. I already told you जो ऊपर जा रहा है, फिर ये superior vesicle है, and you can see the uterine artery. The first transverse artery which runs medially is the uterine artery. Is it right? और फिर उसके बाद, yeah. So I think we can just leave these here. There's no need to remember. Now what you must remember is that when we do an internal artery ligation, each of its branches has an anastomosis with branches which are not branches of internal iliac artery. So that is why even if you ligate it, there is no necrosis. So all these anastomosis take up. और ये जल्दी से ही हो जाता है, तो इसलिए ये नहीं कि हम, it will last for a long time. How it acts is that it reduces the flow of blood, blood flow into the arteries and veins. So it allows a thrombus formation. So that is the way how it acts, and that is why it should be done before the patient actually goes into coagulation failure. जब थ्रोम्बस ही नहीं बनेगा तो फिर कैसे काम बनेगा ना? So बहुत लेट करने में it does not have a place. You must do it at the right time. Is it right? So that is why you have to be with it. All right. So I think we can leave this. Okay. So step by step, stereognosis, tactile sensation, feel and identify. Palpate करिए उसको, get friendly with it. Is it right? So when we have dogs as pets, तो हम थोड़ा पेट करते हैं ना, तो इनको भी पेट कीजिए और देखिए बार बार, है ना, कि कहाँ से कहाँ आ रही है. Second step is visualize. That means you open the peritoneum. We'll tell you how to open the peritoneum safely. और फिर उसको उनको देखो खोल के. Is it right? And you can even use the suction and dissect. Well, this is external iliac, this is psoas. We'll tell you what all. And this is external iliac vein. And थोड़ा और अंदर जाइए, And you can always use suction. जब डायसेक्ट करते हैं, go along the artery. आर्टरी को कुछ नहीं होता, वेन के ऊपर ज्यादा प्रेशर नहीं होना चाहिए, पर आर्टरी के ऊपर आप कर सकते हैं. Is it right? And the third step is then you go right up to the anterior division, और फिर उसके नीचे से क्लैंप पास करिए. You may not tie it. But you should know how to pass a clamp, because when you are actually in a mess of PPH, you can't start it for the first time. Let's understand that. So it has to be done in a patient who is stable. और जब आप ये सब करते हैं, first two तो आप अपने आप कर सकते हैं. Third के लिए you can have someone who is already doing. You have people here, and you can have masters who can be trainers, and that is how you will start. Is it right? So that is from Mitra's end. So what she says is that sweat in peacetime, if you don't want a bleed in wartime, right? And journey of 1,000 miles start with a single step. You all have to decide that you want to do an internal artery ligation. And this mission needs commitment. Till the last practicing obs and gynae is conversant with it. And she's done a lot of work in this. So she says you are not a leader until you have produced another leader who can produce another leader. So you have to have your own clones. It is no point if I can do an internal iliac artery and people who are there with me. I cannot. So from SGT, when I told them that, I'm recently joined SGT. So when I told them I'm going to Jammu for internal iliac ligation workshop, so the girls told me, ma'am, aap hame to sikhaiye. So I said, yes, if you don't know, I will. And lo and behold, Thursday we had a discussion. Wednesday and Thursday they had a patient of PPS, so they called me. So we did our first internal artery ligation there. And I did one side, the other side the assistant professor with me did. So this is how we have to go ahead. Is it right? So first we have to be confident. अगर हम ही fiddle करेंगे, तो फिर बाकी लोग को कैसे सिखाएंगे? I think that is what is important. So my my request from Mitra's side, she wanted to be here and she's very passionate about, and Dr. Arun had actually been interacting with her, but she had some last some moment, some urgent commitment, wherein a family commitment for where she had to go, and that is why I am delivering her talk, right? So my request to support her, and thank you. Yeah.
So much for the enlightening session. It was great, and thank you so much. I have remembered the mnemonic. I'll surely teach it to the children.
Lovely, yeah.
Thank you so much, ma'am, for such a wonderful session. The lesson for all of us is that before the patient breathes, before the patient has massive blood loss, we should always try internal iliac artery. And as per me, carry home messages. Next time, whenever I will get chance, I will try to do this internal iliac artery. Thank you, ma'am. Thank you so much.
Thank you so much.
I'm my senior and I don't want to tell, I just have a comment. The recent AJOJ, the American Journal of Obstetrics and Gynecology, they have written a big review of a lot of multicentric cases and papers in which they have said that internal iliac artery ligation is much better than the catheter we put. We put catheters and balloon to inflate because it takes lesser time. We can do it at a lesser time. The blood loss is lesser and the patient recovery is faster. That is in 2025, August 2025, they are going to come. It is there, and I've already shared it. And those of you who are there in my 1 minute reads, I've already shared it. So internal iliac artery is coming back. Even American Journal has accepted that internal iliac artery is better than the other.
Ma'am, your this very internet. We can do also those ring operations atonic PPH. They will work also. No, atonic PPH.
No, actually, each you don't have to do internal iliac ligation as the first go. So if you have atonic PPH, you can go with brace sutures as well. But I think that when you have PPH, it is important that we are skilled in all the surgical skills, which can be done stepwise. Yeah, absolutely. So it should be very clear.
They have not compared the indication. They have said those patients in who need internal iliac, or on those whom we are trying to put the catheter, call the radiologist, try to put the catheter and balloon. That also I have done sufficient patrita for those patients. Electively we put the balloons and then we
and even these days, you have lot of patients.
Internal iliac works for them.
No, you have lots of doctor. You have lots of patients now of cesarean scar pregnancy, placenta percreta. So where the role is emerging more. So that is why this is a comparison maybe for patients who have cesarean section complications. Wherein they have compared and they said that internal iliac artery ligation versus interventional radiology. So that is what is the paper which he is referring to, right? Okay, yeah.
Good afternoon. I just wanted to add one thing in continuity of ma'am's talk, that brace sutures, which sir was talking, is one of the modality of management of postpartum hemorrhage. But then we have different modalities of management of postpartum hemorrhage. Like we have medical management, we have balloon, we have brace sutures, then step-by devascularization of SPART is internal iliac, then hysterectomy. So if you know brace sutures and bleeding is arrested and patient is hemodynamically stable, it is okay, you stop there. But if the patient is still hemodynamically stable and breathing is not controlled with brace sutures, then you have to move on. You have to move on to internal.
Where the other methods fail, we have to do it.
So this is a skill which is really a life-saving skill, and you must learn. Suppose you are because there are hardly very few hospitals in India where there is radiological facility of interventional radiology, and even if that facility is available, your patient is bleeding, and you will call your radiologist friend, please come and help me. They will just take time in coming and going. In that 7 to 8 minutes, your patient will bleed to death. So you must develop this skill. It is you know, you are having an epidemic of placenta albita spectrum also. So every obstetrician must learn and must be familiarized with.
Yeah, as we go around further discussion on this, we will develop on it. So I think we can move on to the next talk. Yeah,
It's
we
difficult
can.
for doctors.
We must learn on cold cases or in maybe gynec hysterectomies. We can learn and teach our residents.
These vessels are not ordinarily injured unless you want to injure them.
Absolutely, absolutely. I fully agree. No,
Otherwise, if you
yeah.
know they are not being, it's very easy procedure. It's not.
No, the aim of this workshop is to tell you that it is not difficult at all, but we need to use caution and we need to be skilled in that. So I think with this session, we put the things to rest now and we can move on to the next talk. Otherwise, we are, short of time. Thank you. Thank you, ma'am. Please request you to stay back. This is for the felicitation of our chairpersons once again. May I request again the President and Secretary of JOGS, Dr. R.C. Sharma sir, along with Dr. Manjusha Bajaj ma'am, accompanied by distinguished speaker, Dr. Manju Puri ma'am, kindly do the felicitations in order. Firstly, Dr. Vishwav Gupta sir. Thank you, sir. Next, Dr. Rajni Gupta, ma'am. Thank you, ma'am. Then we have Dr. Shivani Gupta. Thank you, all the dignitaries. May I request you to be seated. So, very quickly, I would move to the next scientific session. So for this scientific session on the topic extraperitoneal approach of internal iliac artery ligation, and for this may I invite upon stage the chairpersons, Dr. Geetu Mahajan ma'am. A big round of applause for her.